Okay, so we're going to get going on our last session here. And I want to thank everybody for being here, being present online and in person. So this is our culminating session. It's called Next Steps, Being a Healthcare AI Ambassador for Responsible Use. We really hope this session turns what you've learned into action. So I've been stretched. I think we've all been stretched. We're getting a lot of meat. How do we take that back to our organizations? So we're incredibly fortunate to close today with two national leaders from AI Health Partnership at Duke University. First, we're joined by Alifia Hassan, who's an MBA, and she is the Innovation Portfolio Manager at the Duke Institute for Health Innovation. Alifia coordinates major national initiatives like the Health AI Partnerships and its groundbreaking practice network, which supports safety net organizations, including community health centers and critical access hospitals, in navigating real world opportunities and risks of AI adoption. So she has both, she brings a lot of technical and clinical research experience to her work, and her focus is on making AI safe, effective, and practical for teams on the ground. Joining her, we also have Dr. Mark Sandek, who's an MPP and he is the Population Health and Data Sciences lead at Duke. He leads an interdisciplinary team of clinicians and data scientists to build, test, and scale AI tools that solve real clinical problems, from inpatient deterioration to chronic disease management. He's had a lot of publications in a wide variety of formats. He's advised national bodies like the AMA, the White House, OSTP, and most recently testified before the US Senate on AI in healthcare. He also co-leads the Health AI Partnership, working to ensure AI tools are integrated responsibly across diverse care settings. That's enough talking from me. We're going to let you guys get back into the meat of how to be ambassadors of AI.
Thank you. And thank you, Sylvia and the CalTRC team for inviting us. It's a privilege to be here and to continue partnering with you. So I didn't get my disclaimers in time. I do have conflicts of interest. I'm an inventor of software licensed from Duke there's about 4 or 5 companies, including Cohere, Cohere Med, Keela Health, Vega Health, and Clinetic and Full Steam. So we've built a lot of things over the years that we have tried over the years also to kind of commercialize. So I'm here presenting with my colleague Alifia. We've been very fortunate over the years to both be ambassadors of AI implementation within Duke through kind of the main hats that we wear at the Duke Institute for Health Innovation, and then in safety net settings at a national level through Health AI Partnership. So these are the topics that we're going to go through today. I'm going to be handing off to Alifia when we start going through the responsible AI adoption pathway, where we're going to highlight kind of very specifically what you all can do within your organizations to go through the AI product lifecycle. So I don't think I have to motivate this. I imagine everyone in this room wants to make the most responsible use of emerging technologies. So I know Sylvia was just mentioning this beforehand, but I think it was just within the last 6 to 12 months that the number of FDA-approved AI devices has surpassed 1,000. I do want to highlight the speaker from earlier this morning. Really, Michael Abramoff kind of paved the way for a lot of these innovators to get regulatory clearance as medical devices. We see a growing kind of number of use cases that are getting validated in practice that have positive impact on clinical outcomes, on workforce burden, on efficiency, on access to diagnosis and screening. We also see a lot of cases where AI is not having the most positive impact. Sylvia mentioned beforehand the use case of it was Optum building a kind of a risk prediction model for care management that was modeling cost instead of acuity of care. And then we also see growing unease and uncertainty amongst patients around how AI is used in their care. So we're here to try to help folks who want to bring emerging technologies into their care setting. And what I like about this too is it really reflects the way that we do innovation within Duke at the Duke Institute for Health Innovation. So want to emphasize that bringing AI into your organization should always center around some problem or opportunity to improve patient care. So for us, a lot of the projects that we work on are driven by frontline clinicians who actually submit to be able to work with us to do implementations of emerging technologies. And we also just encourage you all, as you go back to your organizations, keep an ear to the ground of what the clinical problems are that you're facing that AI may be able to solve, but always be trying to ground it in what is the problem you're trying to solve. Second is, and I really view this as kind of part of the culture of the practice of medicine. So much of how medicine and medical training happens in the world is this peer-to-peer network and training and apprenticeship model. And we've really leaned into that with all of our work in Health AI Partnership. I was telling someone earlier that for me, a long time inspiration of the work that we're doing is also Project Echo, extension of community health outcomes. And we just have seen over the years many examples of experts who make themselves available to train and provide support to other individuals practicing in lower resource settings who may not have that expertise in-house. So, of course. Yeah, so, oh, so this is so much louder. Could people not hear me at all before? It like wasn't working. Okay. But yeah, we have started to create these communication channels through Health AI Partnership. We have a monthly event. And I know, Jen, we've talked with people who are trying to build these networks locally too. So I think Cal TRC, the TRC network, the HCCN network, it's going to play a big role in helping build these capabilities. And then lastly, you can go to our website, you can go to Cal TRC. They have their own kind of playbook and handbook, lots of these implementation guides. Okay, so how did we even get started to think about this? So I like to tell people the story of we were doing this work at Duke. Sylvia was really one of the first ones to start kind of pushing us to say, okay, like, so you're doing this in the ivory tower. How do you get this out of the ivory tower? But we were also very fortunate to interact with the Gordon and Betty Moore Foundation, who saw what we were doing and they gave us a charge for, okay, how do we scale this? How do we scale these capabilities at a national level? So the mission of what we started and what today is Health AI Partnership is to empower professionals within healthcare settings to use AI safely, effectively, and ethically through these community-informed, up-to-date practices. So really trying to bring the best practices from the ground up. We want to be the trusted partner. And we also know that for this to scale, we have to do this through partnerships. And then when we think about how we want to use the technology, we want it to eliminate the digital divide, improve patient care, improve the workplace. And going back to that peer-to-peer advocacy, we really believe that communities of practitioners are going to help scale the capabilities. We've been very fortunate over the last 3 to 4 years to build this network. We have many of the best leading health systems that have been kind of at the forefront of developing and implementing AI into clinical care. But then we also launched this last year what we call the Practice Network, where we have 4 federally qualified health centers and 1 community hospital system that are going through one of their first enterprise procurements and implementations of AI. So we are kind of a different player in this space. We're based at a university at Duke. We try to amplify voices and diverse voices. So from the beginning, when the Gordon and Betty Moore Foundation gave us this award, they emphasized this can't be for the Dukes and Mayos of the world. That's not mainstream healthcare in America. We really have to create resources that are broadly applicable. We need this to be grounded in the practice of what's going on in the world. Like you'll see a lot of the things that we try to do is, even though you may go to our website and be intimidated because we're comprehensive, we also try to highlight here's what it looks like when people actually do these things. AI is very interdisciplinary. And I would say this is one of our big challenges actually. most of these peer networks in healthcare are kind of very siloed along professional roles, where you have medical societies, you have nursing societies, you have a HEMA for health information management. The reality, though, is making decisions around how to use AI within your organization will require close collaboration between clinical, technical, and operational leaders. So we try to really kind of speak to all of those different roles. We provide kind of direct assistance to organizations looking to implement these technologies. And we've done this so far in a single cohort, but are looking to build capabilities for future cohorts as well. And then lastly, I would say not necessarily our priority going into this, but what we have found is, and Alia pointed this out, you have this gap right now at the federal level. You see a lot of activity in the state level. And I would say there has not been enough concrete planning for national level technical assistance and capacity building. I think this TRC consortia is as good of an example as any that I've seen of how do we actually do something effective at the national level that's coordinated. But we've had to kind of be a voice, really emphasizing that we need to be convening and collaborating. So this will be my last slide. I just want to highlight a few of the examples. These are all publicly available. I think one of the things I'm going to highlight is not yet publicly available, but it will be publicly available in the next month or so. So we have 8 key decision points that go across the AI product lifecycle. Alifia is going to go into more detail on these. We developed the health equity across the AI lifecycle framework. This was really at the peak of kind of 2023, 2024, leading up to that Office of Civil Rights rule that Alia mentioned, where healthcare providers are now liable for discrimination that results from the use of AI. So a lot of health systems have been trying to figure out, well, how do I minimize the risk of discrimination from the use of AI? And we convened folks to really kind of get at that. We developed the original label for healthcare uses of AI in 2020. We've updated that. This is publicly available. And then the last piece is we have a vendor disclosure framework that we built with 3 leading health systems that had developed their own for all their external procurement. And then we now have a consensus document that we're going to be posting a preprint to in the next month or so.
Thanks. Thank you. And in the next phase of this presentation, what I will do is we wanted make when they're implementing and adopting AI solutions in clinical practice. So I'll go through this framework one by one and call out what are the actions you can take and what are the questions you should ask at each stage, and give examples on what can that look like in a real world solution. So using AI Scribe as an example. So first is in the procurement stage is identify and prioritize a problem. So over here, what you're looking at is you're trying to identify and prioritize clinical, operational, and administrative needs. So this has been a common theme in the presentations we've seen throughout the day, where you start with what is the problem, and the questions you can ask over here is what are the challenges in our daily practice? Is it a high priority? Can this be solved by AI? An example, for example, when you're implementing AI Scribe is what surfaces is chart writing is a very big issue. It causes a lot of burnout, and it is an addressable challenge through use of AI. The second key decision point is define AI scope and intended use. So this is really important, where once you identify a problem, you define where can that problem be solved with this tool and define the scope of use. So clearly define the intended use and scope of that AI tool. So what is the function of this AI tool? Will it listen to just this conversation? Will it have some other history that it also takes into account? what are the indications or contraindications and context for the use of AI tool? Should it be used in all kinds of outpatient clinic visits, or should it only be used in adult primary care visits? Will it work in the same way when doing behavioral health visits and pediatric visits or not? So example would be, we need this ambient scribe to record outpatient primary care adult visits and counter and summarize those into clinical notes, because the way it performs in those visits may look very different in the way it performs in pediatric visits. Then the third is develop success measures. So in this decision point, you're trying to establish clear definitions of success for AI adaptation and identify key performance metrics. So then once you have decided that this is the tool, this is the problem I need to solve, this is where I will solve it, you have to figure out, how do I make sure that this is working well? So you define what success looks like and clearly, and what are clinically important and relevant evaluation metric. And you start to track those at the baseline, and then you start to compare it when you're using it within the AI's tool. So for example, we need to evaluate the accuracy, comprehensiveness, and time efficiency of the ambient scribe. So you try to figure out, okay, what does that look like, and what percentage of accuracy is good, and when do I figure out that this is working well or not working well? Then the fourth decision point in development and adaptation is design AI solution workflow. So then you start mapping out how the AI tool will integrate into the workflow, identify stakeholder, and optimize workflow. So you try to identify who's going to use it, who's going to be responsible, and where should it be used. How are providers using it? What's the existing workflow, and how the tool influences it? So for example, before, the provider would write the clinical notes during the visit or after the visit, but with the use of AI tool, is it recording and then summarizing the tool and directly posting it in the EHR system? Or is it a separate system outside where the clinician has to copy and paste and put it in the note and then approve it? So is it adding to the work burden? Is it removing to the work burden? And you have to think through those questions. The fifth decision point is generate evidence of safety, efficacy, and equity. So in this, the action you're trying to take is collect and analyze data to demonstrate AI tools' safety, efficacy, fairness across all population. So the questions you're probably asking is, how good is AI performing? Any subgroup differences or bias in performance? Can providers validate performance? For example, in this, you would examine if the AI tool performs more poorly for non-English speakers versus for patients with strong accents. And you're trying to map out, does it perform across the board well for my patient population or not? I'll move a little faster. I got a 5-minute sign, but we'll try to get through this. Sixth decision point under integration. So now, once you're done development and adaptation, you're moving into integration, and you're trying to figure out, how do I execute? And this means rolling out with education, training, and structured change management. So you need to figure out how will this work in real world setting? Who needs to change their workflow, and how do I educate them? So that example would be it may perform really well in clinic A because there was already a staff buy-in, there was clinical champion, but may not perform in another clinic where you've not worked on creating that staff buy-in and education. In the last life cycle phase is where we sort of monitor once the AI is in use. So for example, in this decision point, the actions you're taking is the success metrics that you had decided before. You're trying to track them and see if it is meeting those success metrics. And then the questions you're asking is, are they shifting over time? Is it performing better, worse? Do I need to change anything? And the continuous improvement in documentation efficiency after implementation could be an example, right? You'd see times of documentation time spent on documentation reduced significantly post-use. And the last is update or decommission AI solution. So this means where you're trying to figure out, after tracking performance, do I need to decommission? Is the performance shifting, or do I need to upgrade because there's better versions of the tools available? So over here, again, you're trying to track metrics, and then you are deciding when do you have to sunset the tool if it doesn't meet the performance metrics determined. Okay, so this is like a QR code for the 8 key decision point framework handout that went through all those 8 points. And Mark will distribute few hard copies that we have here as well. And this is, if you want to go through details, then this is our QR code on the website where it tracks out 31 best practice guides under each of these 8 key decision points. Sylvia, are we good on time? Are you good on time or should we? Okay, sorry. In the next phase, I just wanted to bring that 8 key decision points to life by showing you some of the real world implementation of those steps. So let's go through why we track those 8 key decision points and why we wanted to, what we saw as we were building the network. I think what we saw was there's a lot of AI readiness gap across institutions. So that question about how do you bring this out of ivory tower and bring it to real world settings in safety net and low resource setting. So what we saw is that there's lots of capacity gap. Guidelines are usually built with resources and with resources of a high resource setting in mind, which is not translate into real world setting. Inputs from the frontline innovators is really important. You know the problem best in the ground level, so we need to make sure we account for that. AI digital divide is real, and without targeted investment and creating collaborations, we may exacerbate already existing digital divides. And then we have to build implementation pathway, and that requires infrastructure, training, expert access, and peer learning networks. With that in mind, we established the practice network, which is like the first implementation assistance program, where we recruited 4 FQs and 1 community hospital. They identified their own use case and their own problem and joined the program to walk through the 8 key decision point, and we in a 12-month-long program. So I'll just go through a very quick case study, and Jen Cortes, Dr. Cortes from North Country Healthcare and Arizona is here with us. So we'll just talk through what steps they took. So for identified problem, they identified documentation quality gaps. So they want documentation burden was a big thing. And they also wanted to make sure that they upskill their staff on basic AI education and implementation. How do you integrate AI in clinical care? In defined scope and use, we agreed upon ambient scribe. That's what they wanted to implement. And then we helped them with coordinated vendor assessment and selection, scoped out initial validation and pilot implementation plan. In development success measures, we figured out what is the key performance indicator they would track, node quality, satisfaction, usage, and under these categories, we defined what would be the metrics they should track and how do you collect baseline data, and we helped create surveys to collect those baseline data as well. Then we helped design a workflow, which is create AI basic one-pagers to figure out what would the workflow look like, integrated into documentation flow, and clearly define the role of AI in the use. In 5th, generated evidence. I think they're right now at 5th and 6th key decision point where they're running a small limited pilot and generating evidence and getting feedback from the early users. And hopefully in the next few months, they would start monitoring the solution, and then they would figure out when do they scale and update it, or either depending on resources and other things, plan to decommission or not continue or continue, right? Okay, so key learnings and future directions. So there are lots of challenges that have been highlighted throughout the day, and how do we change those challenges or create opportunities from them? So first is foundational capacity gaps. We need collective understanding of different types of tools, like how do you do vendor assessment? How do you do patient disclosures? And the opportunity for that is we need to create collaborations and collective networks where we can solve those issues together and learn from each other. There's limited specialized expertise. We've talked throughout the day that there needs to be an ethics expertise, there needs to be legal challenges, there's lots of contractual information that needs to be available. And we need to have, not all institutions will have those expertise. So we need to partner with ecosystem players by networks so that we can solve some of those problems collectively. AI governance systems, clear structure for oversight and accountability. That we need, we heard about lack of federal regulation and a lot of disjointed state regulations. So we need common frameworks of how do we set up local governance and scale those processes too. And then there's obviously resource constraints. So there's limited funding, Medicare cuts are coming, Medicaid cuts are coming. So sustainable financial and technical support, we'd have to stand up some of those technical teams. So I think what we need to do is collective advocacy for public and philanthropic funding too. So what can we do? So get involved and lead the change. You can join learning networks. You can engage in learning, which is already what you're doing here today. You can get involved in pilots, and within your organizations, you can champion adoption conversations too. You can ask about what are the strategies, how do we create readiness, how do we ensure continuous improvement. And with that, hopefully you join. This is the QR code to check out our website and join our newsletter if you're interested. And thank you. I'll take the same questions.
Things just keep getting better and better. All right. We're going to do some questions now. I think we have some time for questions. I have a microphone, so I'm going to use this opportunity to ask my question first because I have the microphone. One of the things I think you kind of talked to a little bit, but I'd like to maybe ask more pointedly is, coming from a telehealth perspective, we had a lot of issues building provider trust in the system and patient trust in the telehealth system. And I see that as a big question for AI too. How do we build provider and patient trust in these AI systems in a reasonable way? Just so that there's a good level of skepticism, but like, how do we get providers and patients on board?
The world has also changed in the last like 2 to 3 years. So when we actually launched Health AI Partnership, I'm trying to remember the exact date. I think it was like March or April of 22. And then of course, ChatGPT came out in September of that year. I would say that, so we used to have all these debates about explainability and interpretability, and like, for provider trust and clinicians, did they need to know the weight of a coefficient associated with a specific input? And now we use language models with billions of parameters, like many people on a daily basis. So it's just, I think we're kind of at a point where the expectation is that these tools create efficiencies, even if that's not realized yet. So a lot of, I think, what we are trying to do is equip people to scrutinize, but psychologically, I think the expectations around AI are so different today than they were in 2022, where people were going to, in some ways, I would say, think much more logically about how these systems perform. Now, like GPT-5 comes out and it's like treating cancer. Yeah.
And a lot of that's based on experiences people have actually had. So it's like something that they know.
No, I'm literally making a joke out of like Sam Altman's announcement.
Yeah.
Of like bringing a woman with cancer and like use this for your healthcare.
All right. The online group got a little short shrift last time, so I want to start with them. Do we have some questions from the online chat?
We sure do. All right. How can a healthcare organization assess its readiness to implement AI use cases, particularly more complex ones, by evaluating whether the right processes, policies, and people are in place? Are there any industry recognized frameworks or best practices available to guide this readiness assessment?
Well, we think about that a lot at Health AI Partnership too. And one of the framework that was not on that product slide because it's still under development and we want to do like more intensive interviews with health systems is our governance framework, where we try to map out people, process, technology, and operation systems and needs that so sort of like infrastructure that you have to stand up within organization. And what does that look like from the AMC perspective? So we want to interview AMCs to FQHCs within the network and outside the network also to understand what are they doing and what are the best practices and how do you set up that minimum governance to make sure that you're ready to implement those AI tools and manage and monitor them responsibly. We did one project with a Canadian hospital system to help stand up their AI policy, where we did similar design workshops to understand their organizational characteristic, their context, what they have already existing. So a lot of times what is happening is they're modifying the existing governance or IT, health IT governance frameworks and adding AI information and questions in that. That's what we're seeing. But yes, that's a common question, is like, how do you make sure that you're ready? And I think the first thing is like, start looking for the communities around you through your HCCNs or telehealth centers or other places where you can participate in pilots. And yeah, anything you'd like?
I was thinking more about your question right before, and this is, I know I can't see Sylvia, but Sylvia or Alia, I would love your sense here too. The idea of trust in that, I would say I'm pretty concerned at the erosion of a lot of prior norms. So like this woman from Stanford, Roxana Danishchu, she just published a paper about when you're using these large language models, the rate at which you're hitting medical disclaimers of like, I'm not going to give you medical advice is going down with like every new version that's getting released. So it's like we're peeling away the norms of like what is a medical device. And then you have like this big controversy that's playing out in public between WHOOP and FDA of like, is this wearable a device that does heart rate? And so like, I just think like historically we would fall back on, oh, there's well-established regulatory regimes around how we classify these things. Whereas now I don't even see those lines holding up in the same way that they used to. So I'm pretty concerned about what that means for how frontline clinicians are going to build trust in these systems.
Would the providers always have time to validate AI? And how long would it take to ensure the accuracy and validity of AI once it has been established?
No.
Yeah.
Y'all have plenty of time, right?
What's the solution, Mark?
No, so I mean, part of what's challenging, and even, I mean, so we talked about like the label and the idea of showing performance data. One of the challenges, and I know we ran into this with Ochin, is even if you're the member of a collaborative and you pool resources to have an EHR instance, what a single clinic still wants to know is, how does this perform for my patients in my clinic, in my geography? So you do run into this constraint of, you want as local, when I say you, this is like the decision maker for a clinic or a hospital is always going to want to make decisions with as local of data as they can get. But what that means is that there has to be capabilities in that context to generate that local data. And there today, those are constrained resources. So we're trying to think creatively about how do we scale that capability to be able to do evaluation and monitoring in every context. But it's not currently kind of the status quo. And it's a huge part of the digital divide, where if you see who is able to evaluate and monitor internally versus who isn't, it's like the big research institutions.
Yeah, and that gets into the question of like you want those large data sets to have something to chew so you can get the outputs that you need. But those large data sets are large data sets and not the small communities that we hopefully are trying to serve. Let's go to another online question, and then we'll probably open it for a couple in the room.
What tips do you recommend for vetting AI vendors?
Vetting.
For vetting.
Well, hopefully our AI vendor disclosure framework would be released in the next month. It's just going through internal review process, but I think it defines 5 domains of like how do you engage vendors and into like what kind of questions do you ask in those domains. So like for system performance, like what are the different questions you should be asking, and what kind of responses should you be getting back from the vendors. And I think two domains that we specifically call out is like what does the implementation and post deployment responsibility spectrum look like? So what is the total cost of ownership? Who has liability for what pieces within the vendors, and what kind of questions you ask on those frameworks? And what is like the data stewardship look like? So who owns the data that is given to that AI system? What is the secondary use of data? And defining some of those questions and answers as well. So hopefully that will address some of those questions too. Yeah.
Excellent resources. Yeah.
And I do think ours even builds off of CalTRC's has one online today. What's it called?
Folks are going to find out. So when we wrap for the California only activity, we'll be sharing that. But the TRCs also are working on some products. And I think there's some extraordinary synergies that were born here today amongst the Health AI Partnership, the TRCs, and the HCCNs.
Awesome.
Could I ask one more quick question? Yeah? Okay. Hopefully it's quick. Do any of the speakers or hosts have any insights on how smaller organizations could secure funding to implement AI?
Do anybody have ideas here? Yeah.
But I know that there are, I know of one organization.
There is one organization that we know of that has been working with Kaiser Permanente. It is part of the research study where they were looking at how can they effectively diagnose, but there are these like community benefits offices that exist in different hospital systems. So here, Cedars-Sinai has a benefits office. So it's really looking at what is it that you're trying to solve and how can you leverage these technologies and be able to do the pilot. But you know more information on that than I do.
Yeah, so I think what Elkin was mentioning is the Aim High initiative from Kaiser Permanente. That was also, I think, funded from the Gordon and Betty Moore Foundation, where they gave out grants to FQ. They included 2 FQHCs, but the grants to do testing and implementation of AI tools. We are also tracking to see for our practice network as well, how do we scale that practice network effort and trying to partner with state and local associations, primary care associations, as well as like foundations to do some philanthropic support, and also tracking if there are any federal funding support. But it looks like Dr. Chandra has something to add as well.
Yeah, I mean, this is a very timely question because within the big and beautiful bill, there is a rural health transformation program that has allocated almost $50 billion for the 50 states. And within that, they are seeking, applications for AI and other emerging technologies on how AI can transform rural healthcare. So small entities that are part of, serving rural areas, underserved areas, there's an opportunity to apply. And that funding, I think, is going to be starting in 2026, going all the way till 2030. So, for example, in Mississippi, the Department of Medicaid has put out a survey, and they are looking for how other stakeholders around the state are thinking about AI and emerging technology. So I think that is true for all the states.
Yeah, I want to clarify that that application has to be submitted by your state. It hasn't been released yet by CMS. It's reportedly going to be released in September, has to be submitted by December 31st. And some states will get more of the 50 billion than others. But to your point, that it is important for you to reach out to your state office of rural health, your legislators, your in the California DHCS, to indicate that this is a tremendous need for your organizations to drive adoption. I'll also just point out that for the California-based folks, CTRC does have a resource of sources of funding around grants, and we will refresh and reprise and repost that in a blog in the next month, so you all can see where there are potential opportunities down to the county level. It turns out in our state, we have some county sources of funding for digital adoption.
And probably shameless plug for those online. I would reach out to your regional TRC. They have their ear pretty close to the ground on funding opportunities, and it doesn't necessarily have to be AI specific. If there are programs out there to help critical access hospitals, FQHCs, just improve. And I think that's one of the things, like with telehealth, we don't talk about it quite as much anymore because it is part of the standard of care. And I think we'll get there with AI as well, as we're improving outcomes. And so, but all right, I think we are at time. Yes, we are at time. So I want to go ahead and wrap up this session, and we're going to hand it over to Sylvia for some closing remarks. But thank you for our speakers. This was really, really insightful.